Thank you for the presentations. We have some questionnaire, and I have the first one for Alexander. There's a question: is there a future for apps in the diagnosis of monitor of psoriasis? For example, measuring PASI during treatment?
Thanks for this. Yes. So I believe there is a future for this. The technology is there. So technically, it's possible to calculate the PASI from pictures. There's even a commercial application, not for patients at home, but in the dermatology practice. Now, to actually allow patients to photograph themselves and calculate the PASI, like teledermatology, you would have to make that app a medical device, which is a big hurdle, and that's not been done yet. And second, you have to change patients' behavior quite a bit. Basically, you have to teach how to do that and so on. So I'm not sure how much the need is really there to go in that direction. But I think we'll certainly try that in studies. Whether that is actually going to influence psoriasis treatment, we'll see.
I have one thing that I always think is a problem. It's that a lot of the pictures that we are receiving is in a quality where it's a bit difficult for a dermatologist really looking into the fine difference in the skin. I think it's difficult, and often, despite it's pictures from doctors, they don't really know what we are looking for.
Yes, I agree. So that's why it's very important that any teledermatology app should have the possibility of the doctor contacting the patient again and asking for more data, additional questions, and so on, before making the diagnosis and giving some treatments, because otherwise it's unsatisfactory for both sides.
I actually have a question from Alexander to Joe, but I will then be the one.
Can I ask a question to Alexander first?
Yeah. Mm-hmm.
Yeah, thank you. Hearing your fabulous talk, I saw that you put the detection of metabolic syndrome in the psoriasis patients as a difficult one. You put it in red. So through teledermatology, I can imagine if you consider teleconsultation, yes, maybe there it's difficult, but how far have you come in Switzerland with data sharing? I mean, you probably have access to the digital data generated by the GP examinations or by other specialists. Do you have them around your patient when you do a consultation?
Unfortunately, no, Joe. But of course, that would be perfect. And I know in Denmark, for example, I think, and maybe in Belgium as well, they are really far. But in Switzerland, everything is about privacy and et cetera, et cetera. So, and we have different regions in the country that all, don't agree and so on. So that's very difficult. So we live with the data that the patient gives us in that consultation. I think it's possible to measure some surrogate markers for metabolic syndrome with questionnaires, for example, but that's not typically the focus of the first consultation, where it's really about initial treatment.
Yeah, I think there's indeed a big need there to have the data centralized around the patient wherever he has been for his care, but that it's available to the current specialist that he is seeing. I agree. Thank you.
Thanks.
Okay, and then we will take the question for Alexander to Joe. He would like to know what you think about the new articles in the IRD, which shows that Th17 inflammation is directly related to the Western diet.
Yeah. The coming months and years, there will be a lot about the gut-skin and even brain-gut-skin axis, I'm sure, also at molecular level. But I would like to hand over to Linda Grine. So I presented work from her as a postdoc in our lab, and I'm sure she's more into the subject of and especially has read this JID publication. I hand over to you, Linda.
Thank you very much. And thank you for the question. It's indeed a very good one, because it really shows also that IL-17, which is of course an important target in the treatment of psoriasis, how it's still linked with what we eat. And with the IL-17, what's really nice is that it's not only a cytokine that is pro-inflammatory, but it also acts very synergistically with all other pro-inflammatory cytokines that in turn regulate a lot of metabolic processes. And for IL-17, for instance, it's known that it plays a role in the acceleration of atherosclerosis. So in this way, I think that the fact that we have a Western diet, which is known to be very rich in fats, and salts, everything that we know is not good for metabolism. I think here it really shows that we shouldn't really see inflammation as something separate from very normal processes like digestion, etc., and that we should really see everything as one whole. And so, yes, in this way, I think it's it makes sense that the Th17, that IL-17 plays a role in lipid metabolism. And in this way, that a rich fat diet can actually accelerate inflammation, and thus not only atherosclerosis, but also psoriasis lesions. Yeah.
Maybe it's interesting to reveal some of the markers you will be measuring over summer. It's really ongoing work in your study.
Yeah, exactly. It's not only that we will look at inflammation, but we will also be looking like metabolic syndrome markers. We will even look at integrity markers. For instance, we will be measuring Claudin-3, we will be measuring intestinal fatty acids binding protein. So we are really seeing everything as a whole, and that's what we try to do. It's not only look at what is inflammation telling us, but what are other markers saying to us, and also in a very time dynamic way. So we have sampled it. We have sampled the patients quite severely. They were still very happy to do so. But it means that when we see a certain change, we can also look back at other markers and see what process was first to respond to a fasting intervention. So I'd say stay tuned, because there's a lot of data coming out.
Brilliant, thanks.
I can tell that I was part of one of the trials that Joe showed, the trial with the weight loss and the reduction in PASI, and we really saw an effect on diabetes. They could, nearly all of the patients ship their diabetes medicine, and several of them could stop their statins. So the major effect is, of course, on the cardiometabolic changes.
Interesting.
Just, I would like to know, what are you telling the patient at the moment before you have the results from your study? What is your advice for the patient?
That's a very good one. I think what was really successful for me was actually seeing that patients, that they felt that it was possible to change their diets. So we didn't only include obese patients, we had also patients who were slightly overweight. But the fact that they felt better, the fact that they had more energy, it really showed that despite the fact that the skin lesions mildly improved, so there was no large effect, it really still shows the patients that they can take control over something that they often, it's a decision you make 3 times a day, you eat 3 times a day. And so the fact that they can take a decision 3 times a day for their health, for their skin, for the way they feel about themselves, that was actually very empowering for the patients. So I would not necessarily advise patients to do, for instance, intermittent fasting because of the effects on the skin. But I would mainly suggest to do this and to use it as a sort of dietary intervention, to be more mindful of what they eat and how their diet behavior impacts the way they feel about themselves.
And for how long have you decided to follow them up? Because my experience is that it's really difficult to have the patient continuing on a more healthy diet.
Yeah. Maybe I can comment on this, because in the past we have also applied a holistic patient approach to a group of patients. It was called Skin Deep. And what we saw is that patients went better much faster in many ways. This program lasted for 3 to 6 months. And we saw that after 1 year, the beneficial effect had was completely gone already. And I was also advising Linda in this study, the fact that patients feel they are being coached and they have appointments, and it motivates them. And it's always, the question, when this network behind them goes away, whether they keep on motivated and keep on doing this in the right way. Probably not. That's why we are trying to include this into our consultations. So to have an integrated approach in the consultations themselves, to have it on a continuous basis.
Yes, thank you. And that was actually also a question for me. And it's sometimes patients have their own perspective on the disease severity, which can be subjective. Are there any plans in the future to include subjective patient perspectives in the disease classification? And that is actually a problem. And that is also why we try to test this classification in different way. Looking at clinical trials where patients turn out to be not have response to topical treatment, to see how is this the patient characterized. So maybe we have to put more into the definition. And it's also I think also it could be a problem that the one who has developed it is specialist in psoriasis. So I think that they have much more knowledge about psoriasis and treatment and which fits for the patient compared to just a GP, and they cannot directly take this definition over. So I think we need to have it more characterized. So, Alexander, do you think that we only need half of the dermatologists in the future due to all this teledermatology?
No, I think we will need about 3 times more dermatologists because people are really now have a much higher demand for procedural dermatology. So we have long waiting times. I'm now very focused that my residents learn procedural dermatology. So we have an own aesthetic dermatology clinic that is also in quite high demand now. I'm quite relaxed about doing aesthetics at the same time as medical dermatology. I think we have to change course a little bit and do both on a high level. And right now we're also getting, problems, secondary effects, and so on, as referred. So we will change what we do a little bit if the diagnosis is not that in the center anymore. But let's face it, I mean, the rare stuff will not be so easily diagnosed by computers, nor will we ever be replaced by friendly robots that care for the patient. So there's no danger for us at all.
It is so correct that you couple this to the tremendous rise in skin cancer to be expected in the coming decades. So it will balance out. I'm sure it's not a threat, teledermatology, but it's finding a new balance.
And maybe new treatment for diseases as we are not used to treat, much more effective treatment for vitiligo and alopecia areata, and who knows. So
yeah.
There's a last comment. There is one asking for how you can get into IPC as a dermatologist, and I think that you should write to them. There's an email on the homepage. and some countries there's a lot of consults, but in some countries there's none, and there's really a need for consultants all over the world. And I think,
may I say some just personal remarks? So if anybody of the audience is interested in joining a machine learning project and has an in-house picture collection, then we can now actually work together without you having to share the pictures, but just by combining the computer resources. We're doing a global project on that, and it's skinsight.ai. Happy if anybody.
Can you put it in the chat? Skin fight? Oh.
Yes, I will put it in the chat. Thank you.
Thanks. Great.
And thank you. Actually, I think that there's a plenary session now, so I think I will thank everyone for participating and listening, and have a good day the rest of the day. Bye.
Thank you.
Very good.
Thank you.
Bye.
Bye.
Thank you. Bye.